Hello, everyone. I'm Devi Nair. I'm a cardiac electrophysiologist from Jonesboro, Arkansas in the United States. I'm here at the EHRA studio by ESC TV. And today we're going to discuss the role of intracardiac echo during invasive electrophysiology procedures. And this is going to be based on the statement by EHRA and EAPCI scientific document. And I have two very esteemed faculty with me that are experts in intracardiac echo, Dr. Petr Peichl and Dr. Stylianos Tzeis. So welcome to EHRA TV.
Thank you for having us.
Yeah, absolutely. I'm delighted to have you guys here to talk about where do we see intracardiac echo in the EP lab today. So I want to just start off with both of you. Just Petr, I'll start with you, and I want you to get in there, Stylianos, and tell us, do you feel like intracardiac echo is just an adjunct tool, or do you feel like it is an essential tool?
So we designed the document to show that although it's a not new technology, intracardiac echo has been here for some time, it become much more important than just that one tool to guide your transeptal procedure. There are many other aspects that ICE can help you with during easy and maybe more difficult cases in the EP. And that's why we try to bring this document that will summarize the benefits of using ICE for difficult substrates or maybe daily routine, but also for detection of complications. We provide a document that is not only a review of what is currently available, just a review article, but there are all 122 videos associated with it that is available for everybody that can really go in depth and see and understand why real-time imaging is essential for providing a better care for our patients.
How about you, sir?
Well, I strongly believe this is essential. And the reason why I believe that is the vast majority of cases that we do in our EP lab aim to improve the symptoms of our patients. And having this in mind, we should prioritize the safety of our procedures. And intracardiac echo is an essential tool in order to improve the safety. If we have a means to reduce our complications, probably it's even unethical not to incorporate it in our everyday practice, in our workflow, because we claim that we master everything. We don't need it for a transeptal puncture. We don't need it to follow up our cases. It's a bit selfish, and we need to leave the ego out of the door of the lab, because at the end of the day, what matters most is the safety of our patients. And definitely, intracardiac echo is an essential tool to improve the safety of our patients.
So it's a great point, and I want to just kind of elaborate a little bit more on that, because there's always a concern, and we see scientific papers coming out about safety of EP procedures with just ICE usage and not using fluoroscopy. And I just came from a session that was totally focused on reducing fluoroscopy and zero fluoroscopy. What are your thoughts, Petr, on the rate of complications when you're using ICE instead of fluoroscopy, or as an adjunct to fluoroscopy? Where do you see that balance?
So there's this part about the reduction of the fluoroscopy, but there's this part of ICE usage goes more into the kind of detection of some things that is not visible maybe on fluoroscopy. So there's a lot about early detection of potential complication like tamponade. So it's accumulation of the fluid takes some time to occur, and if there is a tamponade, it's already kind of a catastrophe there. But if you know from the intracardiac echo something is coming, you can get prepared and handle everything promptly, effectively, very early on. There's one part of this potential perforation. The other part is detection of the intracardiac thrombi. Part of the document also focuses on the exclusion of the thrombus in the appendage, left atrial appendage prior. We know that there are data out there that the ICE is as good as it can be used as a kind of alternative to TE prior the ablation procedure to exclude it. But the thrombus can be actually anywhere. We saw, and there is a particular chapter on ventricular tachycardia ablation. So these old thrombi can be found also in the ventricle, in the right ventricle for ARVC patients. There are examples of that. So there's a lot of things that can surprise you. If you're not used to intracardiac echo, you just stumble on a complication. With intracardiac echo, you have much more data there. You know what you're doing and what can happen, or what you can prevent, and be ready for whatever is out there.
Totally agreed. I think the two key words is the prevention and prompt detection. So you can prevent the complications, and if you have complications, because the only one who does not have complications is the one who does not perform procedures, is to have a prompt detection which enables you to have the most effective management. So at the end of the day, you can improve the safety by detecting and appropriately managing those complications that are there.
I mean, with everything you guys both talked about, I mean, you would think intracardiac echo is used in every case, but there is definitely not the case, definitely not outside of the United States for sure. Stylianos, let me ask you, what do you think is the barrier? Is it the cost? Is it the workflow? Is it training? Like, where is that? What are we dealing with here?
I think the key caveat is the cost. And I come from Greece. We are not the richest country in the world, but we can overcome this barrier with re-sterilization. If you have a standardized and meticulous re-sterilization, you can overcome this barrier. And I think a minor issue is that we need to persuade the community about the value of ice, because it's not only an issue of cost. Cost, okay, the upfront cost is something that we need to take into account. But there is also another reasoning for this reduced penetration that we have not yet persuaded the average electrophysiologist that he can slightly adapt his ablation workflow and that it's worth adapting his ablation workflow. Because, you know, the change, we are always slightly resistant to change, and we need to persuade that it's worth the change.
Do you feel like we should make it mandatory in training programs to have ICE training?
I strongly believe the training is very important. We obviously training fellows, and what I've learned over the years that it's not that straightforward. ICE is not that straightforward. You have to spend some time to understand what's where. Obviously nowadays you have a kind of easier access with the 3D integration of these probes and to understand what you look at, because then this can be kind of easier to implement. But I believe people try to use the ICE maybe sometimes for the difficult cases, but not knowing the technology, it won't help them for the difficult cases, because it's not that easy, straightforward image what they obtain, and it's a difficult case. So it's kind of combined. So if you want to use it, you have to kind of have an idea how to use it for your advantage, and so the technology be of benefit. To the cost issues, obviously there's a difference between different countries in the EU. Obviously EU as a entity allows reprocessing. In some countries it's on the national level, so that might differ obviously. But if we don't fight for it to have it available, then we will never have it. So it's both part of this cost, but also mindset about. And I believe there's a depth in Europe for the use of ICE, because if you go to United States, you have a use it all the centuries. If you go to Japan, it's also used widely, and in Europe it's somehow they're missing. So, and there are different countries in Europe with different usage. Greece, Czech Republic, maybe Central Eastern Europe is more using it than the Western Europe. And the document tries to somehow compensate and shows that there is something like intracardiac echo that can be used.
And what is also paradoxical is that the Eastern countries adopt more this technology, and theoretically they are not the probably the poorer countries, and they have adopted and integrated this technology. It's a bit of a paradox, and the most rich countries, which are in the West, they tend to resist. But I would like also to add something. It's like the analog of femoral venous puncture, because in our days, every well-organized lab uses echo in order to gain access in the femoral vein.
Yes.
In order to be a bit more daring, why not to have a routine implementation of ICE in order to have the transeptal puncture?
We completely agree. That's why we're here, and that's why I try to promote the technology.
Yeah, I mean, I think, we routinely, even in the US, I told you, I mean, we use ICE in every AF ablation, but using ICE has so many meanings, right? It could be just ICE for transeptal, and then they forget that there is ICE.
Of course, exactly.
Right? And then you use ICE to a whole different level of assessing contact and actually integrating it in the whole procedure. Like you said, looking for thrombi, looking for complications, being proactive. So there is a whole different learning curve. And to me, I feel like I become a much better operator when I start focusing on ice. I make my techniques better because you see things that otherwise you just don't see. Now, let's just talk a little bit about the future. There's so many innovations coming in ice, whether it's the development of 3D ice, 4D ice, or ice integration into mapping systems. What is it that excites you the most, Peter?
Yeah, these 4D ice and all these new, very complex technologies will be coming and are coming. It's interesting. What we really need, maybe from kind of European perspective, is more like a focus on price. So provide these probes a bit kind of affordable. So I'm not sure that these very complex, that might be used for structure interventions and very complex cases. That's true, but what we maybe need is more simpler version of it, just to provide most of the basic stuff, which is good enough. And so that's what I really like. On the other hand, is this integration of AI into tracing of the automatic contour of different chambers. So even before entering left atrium, you have already map of the left atrium that's already here, and I believe that can be used very much to advantage. So
yeah, it helps you, kind of be good at the therapy we deliver, right? Like you talk about AI allowing us to understand the tissue more than just seeing the tissue, like the thickness and just knowing the anatomy is it's a whole different ballgame at that point.
And also, in order to be a bit more provocative, using ice in your everyday practice for example, for AF ablation and ensuring that you have adequate contact, it's almost, it reduces, I will not say eliminate, the need for also the 3D map. Because practically, if you have a single shot catheter and you have your eyes, you practically can validate you have adequate contact. You don't really need the 3D map. Okay, this is probably another adjunct tool, but cost-wise, you can reduce the cost if you realize that you reduce the need for other tools in your everyday practice.
Yeah, I mean, I completely agree. I think we have so many good tools. We have ice, we have fluoroscopy, we have mapping systems. I think it's important for us as a community to understand where do you mix and match to get the best efficacy and the best safety. And I think it's important for us to think of us as operators that to hone on those skills and get better at those skills. And it's great to see experts like you in Europe that are promoting ice. And I think, I believe physicians should take advantage and come to your labs and understand this. And like you said, all these videos that we have, all these virtual content, there's so many opportunities to understand more about ice.
And Devi, I think we should move out of our comfort zone.
Yep.
Because our comfort zone doesn't allow us to change our practice and to use ice. If we get out of our comfort zone, we'll get better. And I think this is a way out of it.
So let me ask you, as some of the final concluding comments, what is, in let's say in one sentence, what is the one key message that out of the scientific statement that you think that every EP should take back to their lab? And I'll start with you, Peter.
So the ice is real-time imaging. I will just maybe steal this from Stylianos, but he always says the ice doesn't lie. So I will just take it from him. But I believe it's very true because what you see is what you get and what's out there. So I believe that's the most important message.
I think, okay, ice never lies, but it's the magic tool to even enhance our safety, procedural safety, and to improve the level of care for our patients. Because at the end of the day, this is the key question. How can we improve and prioritize safety in our everyday practice?
Yeah. Well, thank you both for a fantastic discussion. It is clear that this is a very evolving space, and ice is going to become critical for us in this field. And it is not only critical for safety, but also precision of care. And the future of ice is bright, is what I would say. It is your ice, right? You always see that. So really, really thankful for both of your expert opinions today. And thank you to everyone who joined us today on EHRA TV from ESC here.
Thanks so much.
Thank you.